Well, welcome everyone to the EKG case for the week of October 8th, 2012. And got a nice case for you this week. Not terribly complicated, but again, there's a handful of things that we can talk about in the case that was sent to us this week by Tom Botele. I hope I'm getting his name right. I think I messed it up last time, but Tom has sent us some great cases. The last time he sent us a case that we used was back in March earlier this year. It was one of the DeWinter T-Wave cases. So thanks for that, Tom. And he is a captain and a paramedic in the Hilton Head Fire and Rescue, and he is somewhat of a self-confessed EKG nerd himself, so I have the highest level of regard for people who are willing to admit that. Anyway, this is the case that he sent. He was an 85-year-old man who presented to the emergency department, or actually presented and called 911 for chest pain, and this was the 12-lead EKG that I'm not sure whether either he or some of his colleagues obtained, but this is the 12-lead EKG, and you see that there's some wide complexes and maybe the rhythm's a little off, and so there's a handful of things that we're going to talk about. Now, before we even get into this, what I'm going to ask you to do is to review last week's case. It was the October 1st case. We went through a stepwise approach to how to interpret the EKG when things look a little bit complicated, and these 5 steps allow you to break things down into very simple interpretation. And I mentioned last week something that I will attest to once again this week. This is a 5-step approach that even now I still use every time I look at 100% of 12-lead EKGs. And if you use this 5-step approach, it's gonna get you home with the 12-lead EKG interpretation. So what are those 5 steps? First of all, figure out what the rate and rhythm are, then the axis, then the intervals, and look for enlargement, specifically left and right ventricular enlargement, maybe atrial also, although clinically that's a bit less important. And then finally, you're going to look for signs of ischemia or infarction, Q waves, ST elevation or depression, or T wave abnormalities. We're going to take you all the way through these 5 steps with this particular 12-lead EKG, and you'll see how if you simply go through these steps, it really makes EKGs a lot more simple. So first thing we're going to do, we're going to look at the rate and the rhythm. So I think most people know the box method. You start out with a QRS complex that's lining up on one of the hash marks, and then you count out 300, 150, 175, 60, and it looks like the next QRS is somewhere right around, I don't know, 65 to 70. We'll just call it 70 or so. So the rate here is probably around 70. The computer's calling it 66. Close enough. Whatever. And then you want to figure out, is this sinus rhythm? Is this some type of ectopic atrial rhythm? What's going on? Well, last week we mentioned that to call something sinus rhythm, really, ideally, you should see upright P waves in all of your limb leads except for AVR. And in AVR, you should see inverted P waves. And if you see those inverted P waves and yet they're upright in all your limb leads, then you're looking at atrial beats that are coming from the sinus node. So step number 1, this is sinus rhythm with a rate of about 70. Now, some people are going to say, well, it looks like there's a first degree block in here. We're going to get to that when we get to the interval. So we're not going to miss anything. We're going to pick up everything. But right now, we're just going to say it's sinus rhythm with a rate of about 70. Some of the complexes look like they might be coming a little bit earlier than others. Maybe this is sinus arrhythmia. Maybe those are some premature complexes, but not really all that clinically significant. We're just going to call it sinus rhythm with a rate of around 70 or so. So step 1, done. Step number 2, we're going to look for the axis. Simple enough. It's upright in lead 1, and the QRS is primarily downwards in lead AVF. That means we're looking at a leftward axis. And as we mentioned last week, every time you go through your steps, you come across an abnormality, you've got to stop and think about the differential. So we've identified an abnormality. We've got a leftward axis. So what is the differential diagnosis for a leftward axis? What kind of things give you a leftward axis? Left bundle branch block will give you a leftward axis. Pacers oftentimes do. WPW. If somebody's had an inferior wall MI and has big Q waves in the inferior leads, that's going to give you a left axis deviation. Left anterior fascicular block, LVH, which was the case last week. Hyperkalemia can give you any axis. We mentioned last week that hyperkalemia is the great imitator, or what I refer to as the syphilis of electrocardiography. Famous physician William Osler used to refer to syphilis as the great imitator in medicine, and I refer to hyperkalemia as the great imitator on EKGs. And if you have a leftward axis, but you've crossed out everything up here, then you can call it just a normal variant. But you need to look for all the different things. So let's take a look at the 12-lead EKG. Is there evidence of a left bundle branch block? No, there's not. You'd be seeing little R's and deep S waves in V1, V2, V3 if it were a leftward axis, or rather if it were left bundle, so get rid of that. Are there pacer spikes? No. Are there delta waves of WPW? No. Are there peak T waves associated with hyperkalemia? No. Is there evidence of left ventricular hypertrophy? Do you see giant QRS complexes, giant S waves in V1, V2, giant R waves out here in the lateral leads, or an R wave greater than 11 millimeters in AVL? No, no, no to all of those questions. So if we just go through our differential, we can rule that out, that. There's no Q waves that we notice there. Get rid of that. Not LVH, not hyperkalemia. What about left anterior fascicular block? Well, last week I said we're going to talk a little bit more about left anterior fascicular block, and a lot of people sometimes, they get confused or they forget what the EKG criteria are to define left anterior fascicular block, or actually this should be left posterior fascicular block. Let's just make a little chart here and make it really easy. Left anterior fascicular block, left posterior fascicular block, right? We'll separate those out. And here's what you'll look for. Don't even bother looking at that. Left anterior fascicular block, you get a left axis deviation. Left posterior fascicular block, you get a right axis deviation. Left anterior fascicular block in leads 1 and AVL, you get a little Q wave and a big R wave. You get the opposite with left posterior fascicular block. You get a little R wave and a deep S wave. And then in lead 3, you get the opposite. You get a little R wave and a big S wave. And then left posterior fascicular block, you get a little Q wave and the big R wave, okay? So if you simply remember one of these, let's say you just remember left anterior fascicular block, then you automatically know left posterior fascicular block because it's the exact opposite. So let's take a look at that 12-lead EKG and see if it has evidence of left anterior fascicular block. Well, we already know there's a left axis deviation. There's also the little Q wave and the R wave, big R wave, in lead 1 and in AVL, little Q wave, big R wave. And in lead 3, you've got the little R wave and the deep S wave, right, in lead 3. So this patient has, very simple, this patient has a left anterior fascicular block as the cause of the leftward axis. Okay, so this is where we are now. Now we'll move on to step 3. We're going to look at the intervals. What are the intervals we look at? We're going to look at the PR, we're going to look at the QRS, and we're going to look at the QT segment. And this is the one part of the EKG machine interpretation that you oftentimes can look at and is usually fairly reliable. But let's kind of ignore that for a second. First, the PR, you notice that this patient has a prolonged PR interval. It's greater than 200 milliseconds, greater than one big box. So this person has a first degree AV block. Enough about the PR. What about the QRS? Well, this patient has a wide QRS, is greater than 3 boxes. Again, if you take a look at where the Q wave starts and where the R wave ends, I've exaggerated it here, but this is clearly an enlarged QRS complex. And then if you look at the QT interval, well, the QT looks pretty darn normal, so the QT is fine. So this person at the very least has a first degree AV block, and the patient has an increased QRS complex. So what do we say? When you identify an abnormality, you've got to think about the differential. So let's take a look at the differential that we did last week for wide QRS. What are the things that give you a wide QRS? Bundle branch block, pacers, WPW, ventricular ectopic beats. if a person's got hyper K or severe acidosis, or if they're toxic from sodium channel blocking drugs, or sometimes if they have just non-specific things like LVH, or essentially what I should say is that if they have a wide QRS and they don't have any of these things, then it's referred to as a non-specific interventricular conduction delay. And LVH is one of those things that can prolong the QRS without being attributed to any of these things. So again, let's take a look back at our 12-lead EKG. All right, we've got our differential there. Is there a left bundle branch block? No. You'd see a little R and deep, wide S waves in V1, V2, V3. Get rid of that. Is there a right bundle branch block? Well, there is. Just like last week, there's a little Q wave and a big, wide R wave. And in V2, you've got the rabbit ears. You've got the RS, R prime type of pattern. So this patient does have a right bundle branch block pattern. And just for thoroughness, if you go through the rest of the differential on that we talked about for the wide QRS, this patient doesn't have any of these other reasons. There's no left bundle. We said there is a right bundle. There's no pacer spikes. There's no WPW. These are not PVCs. There's no peak T waves, and there's nothing in the history that would suggest acidosis. And there's nothing suggesting sodium channel blocking drugs. There's no LVH there. So our cause for a wide QRS is a right bundle branch block pattern. So where are we now? Well, we've got a left anterior fascicular block and a right bundle branch block pattern, and that combination is oftentimes referred to as a bifascicular block. But hey, you know what? We've also got a first degree AV block, and this is just a matter of semantics, but when you've got a bifascicular block plus a first degree AV block, that's actually oftentimes referred to as a trifascicular block, if you've ever heard that term. Trifascicular, that's how you spell it. That's what it refers to. A bifascicular block plus a first degree AV block is called a trifascicular block. What's the significance of that? Well, the significance is very simple. It means that the patient has a higher risk of ending up needing a pacer. They have a higher risk of going on to develop complete heart block, especially if it is occurring in the acute settings. Anyway, where are we now? Sinus rhythm with a trifascicular block, rate of 70. And next step, let's look for right and left ventricular enlargement. Well, we can pretty much rule out, for all intents and purposes, rule out RVH, right ventricular hypertrophy, because that would be giving you right axis deviation, which is not present. We'll get rid of that. And is there LVH on this 12-lead EKG? Well, we already established that there's no tall R wave in AVL. There's no deep S waves in lead V1 with tall R waves in V5, V6 that you'd add up to 35. So there's no ventricular enlargement. The atrial beats appear to be fairly normal size. So there really is no enlargement that we need to worry about. And then, hopefully you're with me so far, step number 5. Step number 5 is to look for ischemia and infarction. We're going to look for Q waves. We're going to look at ST segment elevation or depression, and we're going to look at the T waves. All right, so let's look for Q waves. Are there any significant Q waves? Well, there's tiny Q waves, but those are too small to be of any infarction concern. Infarction Q waves should be at least 1 box wide. These are too narrow, and they should be at least 1/3 or 1/4 the size of the entire QRS complex. These are too small. So there's no Q waves here of importance. What about the ST segments? Is there any ST elevation or ST depression? Well, there is maybe just a tad bit of ST segment depression there, just a tiny bit, maybe a little bit there as well. I'm not really sure what to do with that. It's a little bit. What about ST segment elevation? Well, we'll look all around that 12-lead EKG, and you know what? There's a subtle finding here in leads 1 and lead AVL. We're going to blow that up, okay? Specifically looking at leads 1 and AVL. Remember what the baseline of the 12-lead EKG is. It's the TP segment. So if we take that TP segment and we draw it out there, you'll notice that there's just a little bit of ST segment elevation in lead 1. And if we do the same thing in lead AVL, you'll notice that there's just a tiny, tiny bit of ST segment elevation in lead AVL also. Remember, 1 and AVL are lateral leads. Sometimes people call them high lateral leads. So there's just a little bit of ST segment elevation in 1 and AVL, probably not even a full millimeter. But the other thing that really should catch your eye, if you've been following along in this EKG series, the other thing that hopefully by now has caught your eye is take a look at the morphology of the T waves. Notice how straight the initial part of those T waves are. That, normally we want to see T waves that are nice and concave upwards. And then they go, sometimes people refer to that as a smiley face. Let's say there's a person right there, and there's their eyes and their nose, and you see that's a nice smile, okay? In this particular case, it's very straight in appearance, and when the T waves are starting to look very straight, I refer to that as hyperacute appearance. Other people may not, but I think that that's what represents hyperacute or early ischemic T waves, when the initial part of the T wave starts getting straight, because a lot of times you repeat the 12 lead in a little bit, and then they're starting to get more convex upwards. Whenever you see straightening on the initial part of that T wave, you've got to worry that you might be looking at early ischemia. And now we add on the fact that there's just a little bit of ST elevation in those leads. Gosh, we got to worry that this person might be having an early high lateral wall infarction, and maybe that ST depression in the inferior leads is reciprocal. So I'm going to stick that up there as part of the diagnosis also. So where are we? Sinus rhythm with the rate of 70. We've got a first degree AV block and a bifascicular block, also known as a trifascicular block, and we're worried that the patient may have some early lateral infarction findings. And then I didn't mention the T waves. There's an inverted T wave in lead V1, which is very common with the right bundle. There's a flipped T wave in AVR, which is completely normal. Flipped T wave in lead 3 and in AVF. Those are abnormal, and you worry that maybe those are signs of ischemia or reciprocal changes from an early STEMI in the high lateral leads. So I just want to finish off with those T waves. So where are we now? Final diagnosis here: normal sinus rhythm, rate of 70, trifascicular block, concerns for early lateral STEMI, and that was confirmed in the cath lab. The patient had a positive cath. By the way, take a look at the 12-lead EKG machine's interpretation. Nothing about an early STEMI. Why is that? It's because most machines are programmed to only detect ST changes that are at least a full millimeter. And in this case, the ST elevation was not quite a full millimeter, so your machine will not pick this up. Your machine is also not programmed to pick up that straightening of the initial part of the T wave that we talked about. So your machine's not going to pick that up. You've got to be the one to pick up those subtle findings, and that's why we keep talking about these subtle findings. All right, so you've got to notice that slight ST segment elevation, and most importantly, I think, is the straightening of the T waves. This was picked up. The patient went to the cath lab, and I think had a pretty good outcome, positive cath, but once again, don't rely on your machine to pick this up for you. All right, so hopefully, once again, just hammering home that 5-step method to interpretation of 12-lead EKGs. And every time you come up with an abnormality along your journey through those 5 steps, you stop and think about the differentials. We'll continue doing more EKG differentials like this. And if you keep practicing this, those EKG differentials will, like I said last week, become just like the back of your hand. You will know them inside and out, and you're going to pick up a lot of diagnoses that the machines and a lot of other folks may miss. Simple, simple, simple. All right. So I hope this was helpful, and I look forward to talking to everybody next week. Bye for now.